Hello and welcome to Medical Dialogues Journal Club. I am Dr. Nandita Mohan, and today I will be discussing about the Journal of Neonatal Critical Care and Anesthesia, which is an open access peer-reviewed journal which is committed basically to publishing high-quality articles in the field of neonatal anesthesia, common health problems of the newborn and the neonates. So the journal that I'm talking about today that I will be discussing is owned by the NAS, which is the Neonatal Anesthesia Society, and is published by Scientific Scholar. Today we have a panel of veterans from a super specialization subject category of neonatal anesthesia and critical care, which is belonging to the NAS, which is a young society made by veterans in this unique field of super specialization that is aimed at giving care to the newborns and the neonates. So we have with us, who've joined us, Dr. Usha, who is the editor-in-chief and is also the ex-HOD and director professor, Department of Anesthesia, Pain and Palliative Care, LHMC, SSK and KSC hospitals, and also the president of NAS. Dr. Indu, who is the associate editor, professor, anesthesia and intensive care, PGI MER Chandigarh, and Dr. Snehalata from the advisory board, who is a consultant pediatric anesthesiologist, Breach Candy Hospital, Masina Hospital, Mumbai, Maharashtra. Welcome to Medical Dialogues, ma'am. We are really happy to have you all on board here with us today.
Thank you, Dr. Nandita. We are really glad you are conducting this panel discussion, allowing us an opportunity where we can showcase the significance of this society, what our journal is going to do, what are the goals of a society, and how we want to go about, since it's a new society, how we want to go about further. Thank you.
Great.
And I must thank Ms. Meghna Singhania also from the Medical Dialogues, who's also part of this team in making this a success today, including, of course, the members of the Scientific Scholar Journal, that is Dr. Sunny Datta Gupta, one of the chief person with whom we stay in contact, Ms. Krupa Sheth and Pritish.
Wonderful, wonderful. It is lovely to be interacting and conducting this session with you all today. So to start with the interview, ma'am, Dr. Usha, if you could just please let our audience understand the very concept of neonatal critical care. We all know that this is a very core specialty under the vast field of anesthesia and critical care. And actually, if you could just address on what sort of clinical scenarios the specialists usually encounter in this field.
So before I really go into the clinical scenarios, we must understand what is the anesthesia for neonates, what it entails. Critical care is just one part of the neonatal anesthesia, because anesthesia is really a critical subject, whether it is in adults, children or neonates. Now we understand the moment we tell somebody you're going to go under anesthesia, I see their face go blank, and they're very scared. Even I was scared when it happened to me, because you really don't know what you are going in for and what you're going to come out. When you come out, what is it you are in for? And neonates, as we all understand, whenever we see a tiny baby, we are scared of, anybody is scared that if the baby has to undergo surgery or anesthesia, people are scared. So both are risky. And neonatal anesthesia is actually the most challenging branch of anesthesia and critical care. And that is why we always have anesthesia and critical care, because whatever happens is critical in all patients. Now, anesthesia, our audience must remember, is not given just for fun. It is given so that a particular surgery or any procedure can be performed. And in neonates, every procedure requires some sort of anesthesia. So it becomes mandatory that anesthesiologists or medical specialists who are going to provide anesthesia or administer anesthesia to our babies be aware of the challenges that they are likely to face. What is good anesthesia? That is smooth conduct of anesthesia, smooth maintenance of anesthesia, and at the end, smooth extubation, and baby comes out live, kicking, breathing without any external support, and no complications during the surgical procedure. But this is an ideal situation. But many babies are already critical because of the surgical conditions or because of the other risk factors that may be present in them. So what next can we think of? The baby may not come out uh, crying and awake. So what next is that this is my idea, that baby should not come out worse than what it went in with. The baby should not be worse for than when the baby was taken up for surgery under anesthesia. At least that is what we can aim for in babies who are critically ill. Neonatal age, we all know, extends from birth to 28 days of life. And this is the most vulnerable period in a human life. Most critical, most vulnerable, with highest mortality rate. Nearly 4 million neonates die each year, and this amounts to 2/3 of all infant deaths. Infants is children up to the age of 1 year, and nearly 50% of all under 5 mortality. That is children who are under the age of 5. So it's a huge burden on the society worldwide. And to add on the risk, 98% of neonatal deaths are occurring in the developing countries, which India is part of it. So we are equally responsible. Neonatal mortality is inversely proportional to the gestational age. Now, gestational age is a time for which the baby is in the womb of the mother. So, at the time when the baby is born. Now, full term is 37 weeks and above. That baby has nearly 100% chances of survival if the baby has no problem. But as the period of 37 weeks go down, the risk of survival is more. The risk of dying increases to the extent that when a baby is severely premature, which is 24 to 30 weeks, the risk is more than 70%. And in under 24 weeks, the risk is nearly 100%. Though, with advances and care in specialized centers, a few babies at 24 weeks have also survived. So this is the advance which has been happening. Now remember, these rates are just in neonates who are not undergoing any surgery, who are not undergoing any anesthesia. So this is basically to show that it is such a significant thing, like babies who are already at risk of death. Now they come to us with a surgical condition, and on top of that, we have to give anesthesia. You can understand the paramount increase in the risk that these babies have. And this is the challenge that we face as anesthesiologists, neonatal anesthesiologists. And that is why neonatal anesthesia is actually not a sub-branch of pediatric anesthesia, but it deems the cadre of a super speciality of its own. Because everybody cannot be a specialist in neonatal anesthesia, and they require special training. So that goal is what? That after surgery, if the surgery has gone on well, that is a factor which needs to be thought of. It's not all on anesthesia, but if the surgery has gone on well, then anesthesia-related deaths should not occur. And for that, we require to train our anesthesiologists for that. And they must know what are the common direct causes of death. The most common cause of death in these babies is asphyxia, that is lack of oxygen, whatever the reason may be, because it may be airway related, it may be cardiac, and the two systems which are directly involved is respiratory and cardiovascular. So any complications can cause asphyxia, anything can cause asphyxia and immediate morbidity followed by mortality. Other factors which are leading to this are prematurity, low birth weight, infections, birth injuries, and congenital or genetic defects. So if these are added on, the risk is further increased. India contributes nearly to 20% of global live births. 1/5 live births are from India, all world. And we are equally high in contributing to the neonatal mortality rate, which is 25% our contribution. And this is not something to be proud of. This contribution of ours needs to go down further. We cannot be contributing to the neonatal deaths to the extent of 25%. 1/4 of all the neonatal deaths in the world are contributed by India. No, it is not accepted. So this is where the challenge lies for the government and for the society, government, and the health specialists and the lawmakers. So now we have understood neonatal mortality as such is very high. Surgical conditions add on to the neonatal mortality. Anesthesia adds on to the further risk. And the baby's conditions. Now, these babies, when they cannot speak, they cannot give us their history. The only thing they do is cry, cry, cry. And if they're too sick, they just lie, flat, remorse. They don't even make a noise. So when they don't cry, actually crying is a good sign. If they don't cry, that is even more scary. That means the baby is too sick, doesn't have energy to even cry. So that should be a sort of tinkling telling us, be careful. Listen, find out what is wrong with that child. So anesthesiologists must recognize that even if we do not give anesthesia, the society must understand, even without anesthesia, they are at risk. So with anesthesia, the risk is increased. But that is not to say, I say, okay, they are risky, so I don't need to give care. No, then I need to be extra careful as an anesthetist, because they require not 100%, they require 500% of my concentration on them, that care, so that they survive after surgery. They cannot be operated in any operation room. They require specially suitable OTs, where they have equipment in case something happens for neonatal resuscitation, where the OT is thermal controlled for them. A neutral temperature is higher for them than for the adults and children, where the equipment which is appropriate for them, the size of the equipment, the size of OT tables, airway, tubes, cannulas, the wall fluids, there are drugs, everything appropriate to them is available. And of course, the supporting staff also should be well trained in that. Now, we must understand, why are we thinking of all these things in neonates? Because neonates are very different from adults and children. Remember, these babies have lived for 9 months in the mother's womb, where they were provided for everything, and they were in a comfortable, protected environment. Now suddenly they come out. It's just a 5-minute procedure. During the delivery, it's just a 5 minutes. So within that 5 minutes, they have to make a change. The body must undergo changes to adapt from the intrauterine to the extrauterine life. That is, and now when they are outside, the cord is clamped. So now they are on their own. So if the baby is already compromised, the risk increases. And this is the transitional changes or an adaptation process that these babies are going to undergo. And this is what makes it so much more challenging for the anesthetist, because when the baby first cries, a certain change occurs in the heart. The foramen ovale closes and the ductus arteriosus also shrinks, so that the normal circulation, like in adults, happens. But these are only temporary and not permanent changes. That is, we say they are functional changes. And permanent changes occur after the neonatal life. So up to the 28 days, if any insult occurs, which increases the pulmonary vascular resistance or decreases the systemic vascular resistance, these shunts will reopen. Mixing, that venous admixture will occur, causing hypoxemia. And this is what the anesthetist has to keep in mind to prevent. And simply put, there are many factors, but simply put, if the anesthesiologist or anybody, even anybody looking after the babies providing neonatal care, can take care of 5 factors, the 5 H's, that is hypoxemia, hypercarbia, hydrogen ions, hypothermia, and hypovolemia. So if we can avoid these 5 factors, the risk is reduced of reopening of the shunts. And actually, this is very risky, not easy for the anesthetist. However experienced an anesthetist is, these are the 5 factors which are very risky, because it's not just anesthesia, it's the surgical procedure that is happening, and the anesthetist has to tailor to that surgical condition. So expertise is really required to take care of these babies during anesthesia. Now, and when we were students, we were told children are not miniature adults. Absolutely right. I add to it. Neonates also are not miniature children. So they deserve a special area in the medical field, which is just dedicated to them, just like neonatology. And on top of that, we have parents who are so anxious. Imagine somebody, baby, 1 day old, 2 day old, and requires surgery or is suffering from something. Parents are equally distraught. Parents are equally troubled. And on top of that, if we are rough with them in their usual course, that is not allowed. So we need to be patient with them, empathize with them, sit down with them, counsel them, console them, and tell them that your child will not suffer from surgery because we are there to look after them as the anesthesiologist. Your child will be comfortable during surgery, child will be stress-free, pain-free, and hopefully, if everything goes well, the child will be out alive, smiling in your arms. So I think if we can do that, the anesthesiologist has done a good job. When we talk of clinical scenarios of significant in neonatal anesthesia, everything is very significant. Starting from the time that you take the patient in the OT and you put an IV line, it is very difficult to get an IV line. So that itself is a scenario which we need to be careful. And if one vein gets just spoiled because of one or two pokes, gone. The other hand has to go. Same way for invasive monitoring, that is intra-arterial. We have to be very careful not to poke the arteries because they go into spasm very well, followed by gangrene. Then is the airway management, that is holding the mask, laryngoscopy, intubation, placement of the tube properly. So that itself is another scenario which we need to be careful in. Then is any time any mishap occurs, the baby has severe bradycardia and arrest. So resuscitation of the babies, and we call it perioperative neonatal resuscitation, which we are conducting workshops on also. And extubation at the end of the surgery. These babies need to be extubated properly, or if they are going on ventilator post-operatively, then accordingly they need to be sent to the NICU for the ventilation purposes. Accidental extubation is very common because they are very small, the tube size is very small, fixing is difficulty, any movement of the head and the tube gets dislodged and causes problems. Then, like Madam has already enumerated the cases that are so very significant, I will not go into that. And 5 H's I have told that we need to be careful, they can happen anytime. And most important and significant, failure to extubate and failure to survive are the 2 significant scenarios that as an anesthetist we need to be really careful about. That is post-op death or post-op mortality. So anything you see in a baby neonate is very significant. And like Madam said, the cases that for the journal, in neonates everything is new because there's no journal which is catering to the neonatal anesthesia as such. So we are encouraging doctors to publish anything they do, anything that they feel is significant they want to share with the public, they should do so. Everything is innovative in neonates.
Great, ma'am. That was a very nice and a brief explanation about neonatal care that is which is upcoming and which is actually a different speciality that definitely one needs to address today. So now next, coming to Dr. Indu, if you could just tell our audience about the rationale behind forming of the society, when it was formed, and with what objectives was it laid out, and going forward, how the society will be contributing to the medical fraternity.
Thanks, Nandita. Actually, the concept of forming this society was laid down in the year 2019. Before that, we had been having small meetings like CMEs related to the neonates. But the idea of forming a society it came in 2019 when again the brainchild of Dr. Usha Saha, and we were a small group of 18 members who initiated this society, and registration and other formalities. It took some time, and formally a society was formed in February 2020. So that was a great achievement for us because to have a separate society for the neonates is really the big need of the hour in our country. As Madam has highlighted, the neonatal mortality is high globally and more so in developing countries. And like in the surgical patients, the mortality is very high. Our government of India as well as the National Medical Council, they are making lot of efforts to reduce the mortality rate in the neonates, and they have actually come down when we talk about the patients who come with medical illness, the babies who come with a medical illness. But in the surgical neonates, the mortality is still high. One program which has really helped us a lot is JSK, that is Janni Shishu Kalyan Karyakram, and all the surgeries in the neonates are being done free of cost in my institute and in all the institutes. So that has increased the number of surgeries that these neonates can undergo, because many times we had seen, like my institute is the department of like advanced pediatric center is 25 years old, but the neonatal surgeries has really increased over the last 5 years, and the numbers were pretty high even during the COVID times, because these children are operated free of cost because of this programs the government is having. And I'm sure that we'll reduce the mortality in coming years with all this. Like from the time the society was formed in 2020, like we started having annual conferences every year. Initially they used to be in the virtual mode, and last year we had workshops which were conducted pan India. At various places in India we had workshops which were in the physical mode a week prior to the conference, which was in the virtual. So this year we are planning to have a physical conference in July, and the number of members which are there in the society, as I said, we started with 18, now we are 150 members, and the number is still increasing day by day. So we are seeing lot of enthusiasm amongst the persons who are actually practicing neonatal anesthesia, and we are making sure that we enroll people who are actually doing neonatal anesthesia. And at present most of them are all of them are neonatal anesthesiologists only, but we plan to spread the word among us, the neonatologists, the surgeons, pediatric surgeons and pediatricians, those who are caring for the babies. So we do hope that our society will grow a lot in next maybe over the next 4-5 years.
Great, that's a very good initiative, and definitely if you're doing this campaign, as you mentioned it, the surgeries are being conducted free of cost, so definitely the main aim of reducing neonatal mortality has definitely to go high in the coming years. Definitely, yes. Now coming to Dr. Snehalata ma'am, you can just tell us about the need to start the journal. Dr. Indu had laid down the foundation stone, and now talking about this journal of neonatal critical care and anesthesia, what was the need to actually begin this journal, and going forward, what will be its objectives?
Many thanks to all the organizing committee of this session, and I'm very thankful to all of you. So, Journal of Neonatal Critical Care Anesthesia, it's quite dear to us. We have been working on neonates I've been working for more than 50 years, and getting launched with huge enthusiasm from many of our anesthetists, and that's why we had to actually conferences, and then we thought of starting this journal. This is launched with the aim to bring the national and global readership, the latest developments, guidelines, and best practices in this highly specialized clinical domain of neonatal critical care. So I want to mention it is actually a teaching tool for all because you can just open the journal and see what interesting cases were done, how they were done. So it's a very good guideline for all the junior anesthetists or those who have not seen those different surgical conditions. For them also it will be a good guide. So what I would say, anesthesia for neonates is called a essence of pediatric anesthesia. The success with complexity of neonatal surgical procedures and demand for excellence in anesthesia can be achieved only by incorporating technically advanced anesthesia machines, monitoring systems, spatial scales, and various complex invasive procedures. So to learn all those things, I think you need a lot of experience from from the seniors. You need to learn all these things. And in neonates and premature babies, all systems are immature. You take off cardiovascular system, respiratory system, nervous system, organs like liver, kidneys, and also hematologic systems. They are all functionally immature compared to older children and adults. And anatomically and physiologically and functionally, they are different. So the effects of pharmacokinetics and pharmacodynamics of those drugs in neonates differs compared to other older children. And that is where we have to be extremely precise when we are using any of those drugs or any of the inhalational agents, everything, whatever we use, even from fluids point of view. So surgical conditions in such neonates cause significant perturbations, and perioperative management is a daunting task for neonatal anesthesiologists. So our aim or duty is to prevent pain and stress of anesthesia as well as surgery, while maintaining physiological stability or physiological parameters. So anesthesiologist, in short, holds the lifeline of the patient. There are certain surgical conditions or congenital defects which need to be tackled in first few days of life, and some of them are even on first day of life, and some after stabilizing the physiological parameters. So I'll just enumerate few congenital defects which need to be tackled in first few days of life. One is omphalocele. It's a defect in the abdominal wall. Gastroschisis, the all abdominal contents are open outside to the air, so there is a abdominal wall defect. There can be duodenal atresia. It's like a narrowing of the duodenal part of the intestine. Intestinal atresia at any level, ileal or jejunal level. Tracheoesophageal fistula, where there is a connection between the trachea and the esophagus, and there are different types of those. In babies can have imperforate anus, so you have to on the first or maximum second day you have to open the anal opening. Diaphragmatic hernia, where the diaphragm is deficient and abdominal contents go into the chest, so there is a lot of respiratory embarrassment or distress, and those children need to be neonates need to be stabilized. Lung cyst, there can be a congenital lung cyst which can cause pressure on the normal lung tissue, and that can cause respiratory distress. Congenital lobar emphysema, it's like asthmatic lung, one lobe, where the gases go in or the air goes in, but it doesn't come out, and so that lobe particularly goes on distending further, which causes compression on the normal lung, and that is why they go into distress. So that has to be tackled very urgently. A choanal atresia, where there is a narrowing of the nasal passage, and those babies cannot breathe through the nose. I have done one case of bilateral choanal atresia where the baby could not breathe through the nose at all, and even if you try to pass a smallest size catheter, it will not go, and those babies need urgent surgery. Retinopathy of prematurity, that is very common in premature babies. Sacrococcygeal teratoma, it's a big swelling at the end of the spinal canal, and it can be very disturbing for even parents to see that, so that needs to be tackled early. Meningomyelocele, where there is a defect in the spinal canal and meninges and the spinal cord. So that needs to be tackled. It may be closed or it may be open. So open one where there will be loss of spinal fluid. So that has to be tackled urgently. Hydrocephalus. The baby is born with a huge head, and these babies need to have a shunt. The CSF needs to be diverted to abdomen. That is called shunting of the CSF into the abdomen. Necrotizing enterocolitis. This is a common condition in premature babies, and the intestines get affected. Their vascularity gets affected. They can become gangrenous, and then they need to be tackled very urgently. This, of course, happens more commonly in premature babies. So, our care, neonatal care, starts right from the NICU since the baby is born until the baby is stabilized in the NICU after the operation. So, perioperative monitoring is absolutely mandatory. So, all vital parameters like blood pressures, hemoglobin saturation, ECG, temperature, all these things should be monitored. Preparation for the operative room according to the surgical procedure. Now, if there is a hydrocephalus, we need to have a proper positioning of the babies. If it is a meningomyelocele, after giving anesthesia, we have to put the baby in the prone position. So all these things you must prepare in the theater for all these procedures. So at the end, I can say any pediatric anesthesiologist needs full concentration of on the babies. Absolutely gentle skin handling should be absolutely gentle, motherly and empathetic attitude. And last but not the least, why we are starting this journal, this is to give away the knowledge of whoever is experienced or whoever has done a unusual case. And you can find all kinds of congenital defects. And today you may see another next. It may not be even mentioned in the books. So this knowledge should be given to all pediatric anesthesiologists, neonatal anesthesiologists. First is the airway. It is the trachea is very short. It's about 3 to 4 centimeters. 3 centimeters in premature babies and 4 centimeters in neonates. So whenever you are putting the endotracheal tube, it has to be just 1 centimeter above the carina. Otherwise, with change of position, it can come out or it can go into any of the bronchus on one side or the other side. So that one has to be very careful about. Then these babies, particularly the neonates and premature babies, they have a tendency for apnea because they have their respiratory center is immature, and they cannot compensate by increasing respiratory rate when they become hypoxic, or if there is a increase in end-tidal carbon dioxide. So that is one other thing. Then I would say blood volume, because neonates, their blood volume is about 95 ml to 100 ml per kg, and premature babies it will be about 100 ml per kg. So even if you compare to older children, even 50 cc's of blood loss is quite significant for them. So if the hemoglobin is around normal 16 to 18 grams, then more than 15% of blood volume, if it is lost, you must replace it. So that is one thing. And of course the fluids, you have to be extremely careful. They can easily become hypoglycemic or hyperglycemic. Hyperglycemia can cause increase in production of urine, and with that they will have diuresis and they will lose a lot of electrolytes. So you have to, and their heart is dependent upon the glucose level. heart contractility, and glucose level, calcium level, and other electrolytes. So you have, for major surgery, you may have to, in fact, check these levels intraoperatively from time to time. Thank you.
Great, ma'am. So, definitely the message is to read out to the young anesthesiologists who actually should think about neonatal care equally as an adult or a children aspect, because this specialty is definitely that needs to be catered, and which really needs a lot of attention going ahead, considering these specialties growing also in the near future. So coming to the end of this, Dr. Usha, one last thing that I would like to ask you is, why did you choose Scientific Scholar as the publisher of the journal, and how has your experience been so far?
I approached, we were hunting, like it took us 1 year nearly to get this thing started, the concept of it. The main thing was finances. Sabse pehle we thought, what about the finances? And then was whom to go to, because whoever we go to will be will be very expensive. So I was looking for people, and then 2 or 3 people did approach me, and Scientific Scholar was referred to by a very dear friend and a young colleague. And when you trust somebody, so you accept them. And he said, "Ma'am, they are very good. Why don't you give them a try?" I said, "Okay, if you say so, I will." And then when I really talked to them, I liked their approach. I liked their attitude. They were very positive, and the patience with which, because for me it was a first time online publication. We are used to the book, hard copy publication and how to do all that, but online is still new for us. So very patiently, I would say my first contact was Dr. Sunny Datta Gupta, and I admired his patience with me, because I like to know A to Z before I venture into anything, before I sign a contract. So I ate it up over a few, weeks maybe. And I said, don't push me around, but yes, just clear my things and then let me see my finances. So I found them very nice, very helpful, and all of them. Later on, I came in contact with Krupa Sheikh and Pritesh. They were equally cooperative, equally nice, equally patient. Any time of the day I would call them and they'll pick up their phone, or if not, they would respond, and then later on. So this everybody doesn't do. And when we are starting, we require somebody's help. And at any one point, had they not responded, I would have stopped. So this thing happened, and their software, their editorial assist that we are using, initially I did find a bit difficult, but now that I'm getting used to it, like every other thing, it is user friendly. And like I said, anytime any of us are stuck up with the article editing or putting, dropping it into that, they are there to help us. So that is what we require. Maybe after our first or second issues are published, we'll become equally good in handling the editorial assist site also. The publishing department also has professional and with clinical and scientific knowledge and research and background. So that is required. And as I'm understanding how they work, I really admire the work they are doing and the way they are doing it. It's quite a lot of work. It's not just the article we send and we think we've done our best, but no. So much of work, even after 2 or 3 proofs, they would find something or the other to make it par excellence when it is actually going to the audience. So it's quite a huge task. We only provide the scientific material, the clinical material. They do rest of the beautification of the article, which is so required. And overall, till now, we are all very happy. I'm sure Dr. Indu and Dr. Snehalata would also have the same sentiments. And for the time being, yes, and I hope they continue to extend their cooperation with us. And of course, keeping the finances in mind if they are listening to us. And we would go ahead with them for the time being. Also, if this video is going to be watched by many people all around the world, we are open to accepting articles. Our journal is accepting articles. They can visit the website on jncca.org and they can go through the author's guideline and how to submit the article, how to write the article. Everything is given in that clearly. Everything is very clearly given there. So we would be very happy. Now, before we wind up, just one more thing, I will take this opportunity. We brought this book out, Clinical Anesthesia for the Newborn and the Neonate. And this came out just last year in 23 March. January, a digital copy came out and the hard copy came out in March. And this book has nearly 50 chapters. It covers all the aspects of neonatal anesthesia. All the aspects of neonatal anesthesia with pictures where relevant, not too much of wastage on pictures, but yes, wherever relevant, pictures are there. It's nearly a 1,000-page book and it is published by Springer. So I'm sure people interested in neonatal anesthesia, for them, this book is going to be a boon and they should get this book. Whether for the libraries, for themselves, for the departments, and the ebook is also available to read on the phone when they are. And one more thing I'd like to add before we wind up. My institute from where I come, Lady Harding in Kalavati Saran Children's Hospital. Kalavati Saran Children's Hospital is one of the largest hospitals, even before the PGI Institute had come up with the Children's Hospital. And this was set up in 1956, so it is 68 years old. And that is where I had my experience of more than 30 years as a faculty. And as an undergraduate also, I'm a Hardonian, so Harding undergraduate. So that is where, Harding is doing immense work in neonates. So,
great. So thank you so much, Dr. Usha, Dr. Indu and Dr. Snehalata for joining us today at Medical Dialogues. And it was lovely to be understanding the aspect of neonatal anesthesia and how important it is to understand the core subject. Thank you so much for joining us and giving us all your valuable insights. It was lovely to be interacting with all the three of you today.
Thank you, Dr. Nandita. Same here. It was nice knowing you and maybe we'll have further communication and contact with you. Thank you.
Thank you very much, Nandita.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.